Okay, we will start the benign tumor part one. We will start by benign lesions. Benign lesions. The first one is papilloma, is known as barely benign papule or hirsute papilloma. So the papilloma is considered as or barely benign papules, or hirsute papilloma is considered as benign. This is benign lesion consists of row of 1 to 2 millimeter white yellow papule that's on the corona of the glands. So lesion consists of the row of 1 to 2 millimeter white yellow papule on the corona of the glands. The lesion do not contain human papilloma virus. Remember that papilloma is not contain human papilloma virus. Treatment is usually unnecessary. Laser ablation has been reported for many men. This is the row of yellow-white papule in the corona of the glands. As you see here, this is a dermoscopic image illustrates the barely papilloma appearance with coma-shaped vessels. We come to condylomata acuminatum is known as genital warts. The genital warts or condyloma acuminatum. Non-tender wart-like lesions or papillary fronodular lesions. Condylomata acuminatum is STDs, that means sexual transmitted disease, and a wart-like lesion or condylomata acuminatum is caused by human papilloma virus. Human papilloma virus rarely lead to cervical, benign, and anal cancer that lead to wart is rarely lead to this problem. But we have other variant, it will lead to this cancer. As you see here, this is the benign wart in the corona of the penis. This is at the base of the penis, of the glands of the penis. It's known as genital warts, caused by human papilloma virus. Okay, so this is non-tender wart-like lesion. We come to zones balanitis, or known as plasma cell balanitis. As you see here, it is usually the patient is asymptomatic and will circumscribe red, flat lesion that contain pin, as you see here, pin, point, dark red spot is known as cayenne peppers spot. That's the cayenne pepper spots is characteristic for zone balanitis. It may look similar to the carcinoma in situ, and diagnosis for it is by biopsy and histology show plasma cell. That's why it's known as plasma cell balanitis. And so we see the plasma cell in the dermis. Zone balanitis is seen on the glands and purpose of uncircumscribed or circumcised men. Treatment options include surveillance, topical steroid, circumcision, and CO2 laser ablation. This is the same picture as you see here. This is the zona balanitis or plasma cell balanitis. It's flat red with dark red spot in this lesion, and it will managed by surveillance as we just follow up, and if the patient need, we can give the patient topical steroid because it's usually asymptomatic, circumcision because it usually occurs in the glans and purpose of uncircumcised male. The pre-malignant benign lesion. We finish the benign condition. We come to the pre-malignant benign lesion. We have Bausch-Lowrenstein tumor, or known as gained condyloma. Is known as gained condyloma. This is Bausch-Lowrenstein tumor. An exophytic cauliflower-like mass in the genital and anorectal regions. So it looks like cauliflower-like. This is a cauliflower. Typically, the mass, it looks like cauliflower, and it is usually benign. It does not metastasize, but it can be locally invasive and very bad appearance. There are rare reports of progression to invasive ductal carcinoma, and as you see here, is typically like cauliflower lesion, and it is, fortunately, it's benign. So this condition, it's benign, but it's locally aggressive, and it's known as gained. The name is known as gained condyloma, or Bausch-Lowrenstein tumor. Human papilloma virus have been found in this tumor, especially 6 and 11. So human papilloma variant 6 and 11 is associated with Bausch-Lowrenstein tumor or condyloma, gained condyloma. Treatment: complete excision. It tends to recur after inadequate excision. So it is better to do complete excision. We come to Baunoid papulosis. Baunoid papulosis presentation: red, brown papules. So it's red, brown papule, and usually in the glans of the penis or shaft of the penis. The average age of the diagnosis is 20 to 30. So this is the average age for Baunoid papulosis. It is 20 to 30, and it is usually occur in circumcised male. Human papilloma virus is usually identified like gained condyloma 16, but here is not 6 and 11. Human papilloma variant 16 is associated with Baunoid papulosis 16. As you see here, this is again, it's occur in the shaft and glans of the penis. So as we mentioned, it's red, brown papules occur in the shaft and glans or glans of the penis. Baunoid papulosis is generally considered benign. However, they have been rare reports that Baunoid papulosis reprogresses or regressing into invasive cancer, especially in immunocompromised men. Therefore, observation is burdened. Its histologic appearance is similar to carcinoma in situ. So remember, this occur in circumcised male. Okay, so occur in circumcised male, the age of 20 to 30. Compare with carcinoma in situ, if this occur, transform it to the cancer in immunocompromised patient. So histological appearance is similar to the carcinoma in situ. Treatment option available: surveillance, topical 5-fluorouracil, topical imicomod 5% cream, excision, and ablation, laser, cryotherapy, and cauterization. This is the difference between Baunoid papulosis and CIS. The age that the bonoids is 20 to 30. Carcinoma inside of the penis 50 to 60. Here, the bonoid populosis occur in circumcised male. He is uncircumcised, and both have human papilloma virus. But remember, the bonoids populosis, it's human papilloma variant 16. Okay, risk for developing SCC, that's squamous cell carcinoma of the penis, is rare with bonoid population, especially in the immunocompromised, and CIS is 10%. This picture to show you that the papilloma, it's, as I mentioned, barely benign papule or hirsute papilloma occur in the glands row of the yellow-white papule in the corona of the glands. No human papilloma virus with papilloma, and treatment is not necessary but report for laser ablations. Condylomata acuminatum is also benign, and it is associated with, is known as genital wart. The genital wart, so papillary fondular lesions. Here, the wart is associated with 6 and 11 in 90%, which are almost never pre-malignant for penis, cervical, or anus. Okay, so the condylomata acuminatum is not associated with cervical, anal, or penile cancer because it's associated with 6 and 11. The Bosculin tumor is known as giant condyloma or Vourkos carcinoma. So it is cauliflower-like exophytic mass, can be very extensive, locally invasive. Okay, no myths, and also associated with human papilloma virus 6 and 11. And treatment is surgical excision, complete surgical excision. We'll come to the carcinoma in situ, is known as erythroplasia of Coward. Erythroplasia of Coward, or known as Bound disease, or known as BIN. All this is for carcinoma in situ. Carcinoma in situ of the penis or of the benign shaft is called Bound's disease. Okay, so Bound disease, that is carcinoma in situ of benign shaft. Carcinoma of the foreskin or glands is called erythroplasia of Coward. Erythroplasia of the Coward, this is CIS of foreskin or glands. CIS is also called BIN, that's benign intraepithelial neoplasia. Benign intraepithelial neoplasia. 10% of men with CIS eventually develop invasive squamous cell carcinoma of the penis. 10% of men with CIS eventually develop invasive squamous cell carcinoma of the penis. As you see here, this is the Bound's disease or squamous cell carcinoma of the penis in the glands, and it is actually here receiving specific cream known as Curaderm, which is herbal, with this result at the end according to the follow-up of the researcher. Human papilloma virus has been detected in CIS, human papilloma virus type 16 and 18. So 16 and 18 is associated with CIS. And we mentioned that the Bournoid disease is also associated with 16, human papilloma virus 16. And we compare the Bournoid disease and CIS. So both is associated with human papilloma virus, and that's the Bournoid with 16, but the CIS with human papilloma 16 and 18. Presentation asymptomatic, usually appear as red, fluffy, well-marginated skin flakes, usually in uncircumcised men age of 50 to 60 years, rare in circumcised men. Evaluation by biopsy. Treatment option, topical therapy with 5% 5-fluorouracil or 5% imiquimod eradicates CIS in 50% of cases. These therapies can cause dermatitis, which may stimulate worsening of the CIS. The 5-fluorouracil or imiquimod 5%, this eradicates the CIS in 50%, but it might lead to dermatitis. This dermatitis lead to chronic irritation to the skin and chronic inflammation and CIS worsening. If topical therapy fail, it should not be repeated. We will stop this medication at this time. So the dose of 5-fluorouracil 5% topically BID for 2 to 6 weeks. We will use 5%, 25 milligram cream, 25 gram cream, as you see. So it's 5% topical fluorouracil. We have 25, we have 30, we have 40 gram, as you see here. So accordingly, we can use this 25 gram. Imiquimod cream topically 3 times per week at night for 4 to 16 weeks. So 5% cream, we have 250 milligrams single-use packet. Okay, as you see here, each contains 250 milligram single-use packet. Imiquimod, the patient must wash his or her hand after use it with salt. Wide local excision circumcision might be used for lesion confined to the foreskin. Mohs surgeries is best utilized for lesion less than 1 centimeter in size. So we can use wide local excision. The wide local excision is an option. We can do circumcision. This might be used for lesion confined to the foreskin. If the lesion is less than 1 centimeter, so it is best treated by Mohs microsurgery. Ablation such as laser or cryotherapy. Glands resurfacing for lesion confined to the glands. Long-term yearly follow-up is required because of the risk of malignancy. We come to a very important topic is known as lichen sclerosus. Lichen sclerosus, or known as balanitis xerotica obliterans, BXO, balanitis xerotica obliterans, or lichen sclerosus. Lichen sclerosus is now the preferred term for this condition, or for BXO. Lichen sclerosus arises from chronic infection, trauma, inflammation. Remember CTI or ICT, chronic infection, trauma, inflammation. So ICT, inflammation, chronic infection, trauma. 2 to 9% of men with lichen sclerosus develop benign cancer. The mean time for diagnosis of lichen sclerosus to development of benign cancer is 12 years. 12 years. This is the mean time for developing the lichen sclerosus. For developing the benign cancer in patients with lichen sclerosus. So it is 12 years. Presentation, flat white patches, often amoisic patterns. That's on the glans and prepuce, sometimes extending to the meatus or fossa navicularis. This is the typical presentation for lichen sclerosis, as you see, is white patch. Okay, so commonly affecting the genital and perigenital skin, specifically in the glans and prepuce. So it is in the glans, as you see here, and prepuce, and sometimes extending to the meatus and fossa navicularis. Occurring males, circumcised and uncircumcised, and even females. Lichen sclerosis usually asymptomatic. Symptoms might include pruritus, burning, painful erection in males, and dyspareunia in females. 20% of men with lichen sclerosis have associated meatal and or urethral stricture. Evaluation: if lichen sclerosis atypical or progresses rapidly, perform a biopsy to rule out malignancy. Men with obstructive voiding symptoms or lichen sclerosis near the meatal should be evaluated for urethral stricture. Treatment: asymptomatic lichen sclerosis, no therapy required. Symptomatic lichen sclerosis, topical steroid relief itching and burning, and the best choice is 0.1% triamcinolone acetinoid BID topically for up to 2 weeks. So triamcinolone acetinoid 0.1%. Avoid excision of lichen sclerosis because recurrence rate is high. So phimosis may be treated with circumcision. Treat urethral or meatal stricture accordingly. Long-term yearly follow-up is required because of the risk of malignancy. This is histology for low-grade BIN, high-grade BIN, lichen sclerosis, as you see. So this is the lichen sclerosis, and as you see, it's the lichen sclerosis here. This is erythroplasia of Court, genital bound disease, and here this is Boynoids papulosis, and this is flat benign lesions. So this is the risk of progression to the cancer is not human papillomavirus, sensitivity 70 to 80% for this. Boynoid, yes, is positive. Erythroplasia of Court or pound disease, yes, 40 to 100%. Lichen sclerosis, no association with human papillomavirus, and here it's 5% can transform into the cancer. And the erythroplasia is 10% transforming to the cancer, and Boynoid is less than 1%, and flat benign lesion is not known. This is a benign cancer. We'll come to leukoplakia or leukoplasia. Leukoplasia is usually associated with chronic irritation or infection or inflammation, Malignant transformation occur in 10 to 20% of cases. Presentation: sharply marginated wide scaly plaques, often involving the meatus. Symptoms are irritative in nature. Evaluation: biopsy. Treatment: complete excision and long-term follow-up. This is a leukoplakia, as you see here, leukoplasia. And this is after photodynamic therapy or ultraviolet light. We will come to cutaneous horn, also considered as is a mound of hyperkeratosis, usually on the glands. The cutaneous horn is benign. 33% of the horns arise from underlying malignancy. So squamous cell carcinoma usually at the base of the horn. Treatment, complete excision with long-term follow-up. This is the cutaneous horn. And at the base, we have basal cell squamous cell carcinoma of the penis. Okay, but it is usually benign. This is after excision. Squamous cell carcinoma. Squamous cell carcinoma account for more than or equal 95% of benign cancer. Squamous cell carcinoma of the penis is rare in the United States. In some regions like Asia, Africa, benign cancer is the most common malignant tumor in men. Female sexual partners of patients with benign cancer do not have a high risk of cervical cancer. Risk factor for benign cancer, uncircumcised, presence of the foreskin, the most important risk for risk factor for benign squamous cell carcinoma. Circumcision in newborn virtually eliminate the risk of benign cancer. Circumcision before puberty may lower the risk of benign squamous cell carcinoma. Men circumcision after puberty have the same risk of benign squamous cell carcinoma as uncircumcised men. Circumcision does not protect against squamous cell carcinoma in situ. Pre-malignant lesion, as we discussed previously, and chronic inflammation of the penis or penile skin. Phimosis. Phimosis may contribute to chronic inflammation, which might increase the risk of cancer. Botulinum or ultraviolet light type A, that's BOVA, which can be used for psoriasis, increased risk of benign squamous cell carcinoma when the skin is not shielded. Tobacco use, including smoking and chewing tobacco, human papillomavirus infection, especially type 16 and 18. The following agents do not increase the risk of the SCC. Carcinogen topical contact using increase the risk of scrotal cancer, not benign. Sexual transmitted disease other than human papillomavirus 16 and 18. SIMGA, the SIMGA, that's the whitish material under the foreskin, is not associated with carcinogen or SCC of the penis. Presentation. The mean age of presentation is 50 to 60 years, but it can occur at any age. The presence of the benign lesion is usually the reasons for presentation. The lesion is usually not painful, but might have a discharge or foul odor. The lesion may be nodular, ulcerative, and longitudinal, obscured by phimosis. The common presentation location from most to least common are glans, peripheus, and shaft. We abbreviated in GBS. The GBS, glans, peripheus, and shaft. So it is the most common is glans, and B, peripheus, and S for shaft. 30% of the cases, multiple benign site might involve. So 30% of the cases, multiple benign sites might involve. Most benign cancer are superficial and low grade. So most of a benign cancer are superficial. Paraneoplastic syndrome may be present. Most commonly, hypercalcemia. 50% of men present with palpable inguinal lymph nodes. So half of the patient present with this symptom, benign inguinal lymph nodes, palpable inguinal lymph nodes. Less than 10% of men present with distant metastasis. Delay in seeking treatment is common. Men often wait longer than a year. Metastasis. Metastasis is the most common site of um, metastasis is inguinal lymph nodes. So the inguinal here is the most common. But metastasis occur in stepwise fashion from the penis to sentinel lymph nodes, the first node that's involved by cancer, to superficial inguinal lymph nodes, okay, and then to the deep inguinal lymph nodes, and then to the pelvic inguinal lymph node, and last to the distant site. The sentinel lymph node is the first lymph node to which the cancer metastasizes. It's usually located in the superior medial zone of superficial inguinal node group. However, its position is variable, but is usually in superior medial zone of superficial inguinal. Venous lymphatics do not drain directly to the pelvic nodes. Metastasis must travel through the inguinal lymph nodes to reach the lateral pelvic nodes. Metastases do not spread from the inguinal lymph node to contralateral pelvic nodes. Benign cancer can spread bilaterally to the inguinal lymph nodes. Inguinal lymph nodes because of the lymphatic drain to both sides. Distant metastases from most to least common: lung, liver, bone, and brain. So abbreviated in LLBB, that's lung, liver, bone, brain. Less than 10% of men present with distant metastasis. So 10% present with distant metastasis. Workup, history and examination, especially genital and inguinal lymph nodes. If the inguinal nodes are difficult to assess on physical exam, example obese patient, then obtain an inguinal and pelvic CT or MRI with IV contrast. Biopsy of primary lesion. Perform a biopsy before treatment. Excisional, incisional, or core. When organ sparing therapy is being considered, an invasion of corpus cavernosum is suspected. Benign ultrasound or MRI with gadolinium, with or without an artificial erection, may help determination or determine to determine if invasion is present. Biopsy of non-palpable inguinal lymph nodes. Non-dynamic sentinel nodes biopsy. The biopsy is directed at the usual anatomic location of the sentinel node, the superior medial regions of the superficial inguinal nodal groups. This technique depends on the assumption that the sentinel nodes reside in the usual location. Since the position of the sentinel nodes is variable, non-dynamic biopsy frequently miss the nodal metastasis. In fact, some men have developed extensive metastatic disease despite having a negative non-dynamic sentinel node biopsy. Therefore, non-dynamic sentinel nodes biopsy is not recommended because it has a high false negative rate, up to 50%. Dynamic sentinel lymph node biopsy. That biopsy is directed based on the functional information that identifies the true location of the sentinel lymph nodes. So this is the sentinel lymph nodes, as you see here. The sentinel lymph nodes, the various lymph nodes that involved from the benign cancer. We will use this dynamic sentinel lymph node biopsy based on the functional information identified in true location. And this is a very important non-dynamic sentinel lymph nodes biopsy. The biopsy directed at the usual anatomical location of sentinel lymph nodes superior medial regions of superficial inguinal lymph nodes. This biopsy for non-palpable inguinal lymph nodes. Technetium 99 labeled non-colloidal and blue dye are injected into intradermal around the benign tumor if it was not excised, or around the scar if the tumor was excised 1 day prior to the inguinal nodal dissection. The injected material travels from the tumor through the lymphatic channels to sentinel lymph nodes. Preoperative lymph scintigraphy, intraoperative band Hill gamma ray detection, and intraoperative identification of blue stain lymphatic tissue help to identify the sentinel lymph nodes which are excised. When performed correctly, the false negative rate for dynamic sentinel lymph nodes biopsy is 15%. So if performed correctly, we have negative value of 15%. This technique should only be performed by centers that have extensive experience, that's 20 procedures per year. Dynamic sentinel lymph node biopsy is an option for men with non-palpable inguinal lymph nodes, but should not be performed in men with palpable inguinal lymph nodes. Biopsy of palpable inguinal lymph nodes, if the clinician elect to assess inguinal lymph node before the node dissection, percutaneous needle biopsy of the palpable nodes is the performed initial approach if necessary. Thus, this biopsy can be performed with ultrasound or CT guidance. If the percutaneous needle biopsy is benign, then perform an excisional biopsy of the palpable nodes because the needle biopsy has substantial false negative rate. Metastatic evaluation should be performed in patients who have palpable inguinal lymph nodes, who are at risk for cancer in the inguinal lymph nodes, or who have proven cancer in the inguinal lymph nodes. Cross-sectional imaging of chest, abdomen, pelvis using CT, MRI, or PET CT scan. Chest X-ray is an alternative imaging for the chest. Blood tests like serum calcium, liver function test. Serum calcium to check paraneoplastic syndrome, and LFT for assessing the liver metastasis. Obtain bone scan when the patient have bone pain, elevated alkaline phosphatase, or elevated calcium. State that the American Journal Committee classification for cancer, primary tumor TX cannot be assessed. T0, no evidence of primary. TIS, that carcinoma in situ, benign intraepithelial neoplasia, that's known as TIS also. Non-invasive, that's TA, non-invasive localized squamous cell carcinoma. So that's non-invasive localized squamous cell carcinoma, that TA, non-invasive. T1, that's in the glands or foreskin or shaft. In the glands, invade the lamina propria. In the foreskin, invade the dermis, lamina propria, dartus fascia. So dermis, propria, and dartus fascia. DBD, that's dermis, propria, and dartus fascia. Okay, or shaft. Shaft invade connective tissue between epidermis and corpora, regardless the location. So the T1 in the shaft is invade connective tissue between the epidermis and corpora, regardless the location. This is TA, non-invasive. As we mentioned, that the TA, non-invasive, localized squamous cell carcinoma. T1 in the glands, reach the lamina propria in the gland. In the foreskin, invade DBD, that's the dermis, lamina propria, and dartus fascia. In the shaft, tumor invade connective tissue between epidermis and corpora, regardless of location. T1A, tumor is without lymphovascular invasion, perineural invasion, not high grade. This is a T1A. Tumor is without lymphovascular invasion, perineural invasion, not high grade. T1B, tumor exhibit lymphovascular invasion, perineural invasion, and high grade. So T1A, not high grade, without lymphovascular invasion, perineural invasion. And here T1B, tumor lymphovascular exhibit vascular invasion, perineural invasion, and it's high grade, grade 3 or sarcomatoid. This is not grade 3 or not or sarcomatoid. This is a general description for the layer of mucosa of the glands and foreskin. As you see, that's the lamina propria invaded by T1. T1, we mentioned that the T1 in the glands invade the lamina propria here. And we mentioned that T1 in the foreskin invade the dermis, lamina propria, and dartos fascia. So invades the lamina propria, this layer here, lamina propria, and dartos fascia. And the last, it's invade lamina propria, dermis, and dartos fascia, and the last is a shaft between connective tissue, between epidermis and dermis, connective tissue between epidermis and corpora. So this is the skin, and this is the dartos, and this is the dartos, and this is the buccal fascia, and this is tunica albuginea, and here this is the corpus cavernosa. The corpus cavernosa. Inside we have corpus spongiosa. So this is the T1A and B. T2 tumor invade into the corpus spongiosa. That the T2 tumor reach the corpus spongiosa, but not invading the urethra, with or without urethral invasion. So that's either in the glands or ventral shaft, in the glands or ventral shaft, so invading the corpus spongiosum without or with invading to the urethra. This is the T2, invading the corpus spongiosum without or with invading to the urethra. T3 tumor invade into the corpora cavernosa, including the tunica albuginea with or without urethral invasion. And I mentioned that the T2, the corpus spongiosum, either glands or ventral shaft, but the T3, including the tunica albuginea with or without urethral invasion, invade the corpus cavernosa. T4, tumor invade into digestive structure, sacrum, scrotum, prostate, pubic bone. This is a T4, prostate, pubic bone, and scrotum. T4, pubic bone, and even scrotum. Regional lymph nodes on clinical stage, CNX, cannot be assessed, CN0, there's no palpable visible lymph nodes, CN1, palpable mobile unilateral, CN2, palpable mobile more than or equal to unilateral or bilateral inguinal lymph nodes, CN3, palpable fixed inguinal nodal mass or pelvic lymphadenopathy, unilateral or bilateral. Regional lymph nodes pathologic still based on the biopsy or surgical specimen, but the clinical on the evaluation. The BNX cannot be assessed. BN0, no lymph nodes metastasis. BN1, less than or equal to unilateral, inguinal or no extra nodal extension, BN2 more than or equal 3 unilateral inguinal metastases or bilateral metastases, no extranodal extension, and study that extranodal extension of the lymph nodes metastases or pelvic lymph nodes metastasis. D, distant metastasis, M0, no distant metastasis, N1, distant metastasis present. The grade, higher grade imply worse prognosis, as you see, grade 3, that's poorly differentiated, undifferentiated, or sarcomatoids. Intermediate grade, grade 2, that's moderately differentiated, and the best descriptive grade is low grade is grade 1, well differentiated. This is the end of penile tumor part 1. We will meet again in part 2.